insulin. Amylin, remember I said amylin with insulin is co-secreted by the beta cells and is deficient in both type 1s and type 2s. Amylin also exerts a very important role in the glucose homeostasis and regulation. It is secreted by the beta cells of the pancreas and decreases the production of glucose from the liver, and again the same function, slows the rate of absorption of the nutrients from the stomach, goes to the brain, decreases appetite, as well as improves finally the glucose homeostasis. The brain, these are all I mentioned, food intake and all of that. It is first reported in 1987. It's a 37 amino acid peptide secreted together with insulin from the pancreatic, and it's deficient in diabetics, and is stored in the pancreatic beta cells, and is and with the amylin and insulin levels rises and fall in synchronous manner. Amylin and insulin have complementary action in regulating nutrient levels in the circulation. It decreases the rate of gastric emptying, I mentioned that, suppresses glucagon secretion, thereby hepatic glucose production, and promotes satiety and decreases appetite. It's used also as an injection. We have what we call Simlin. I'm sure you all know about Simlin, which we also use for type 1 diabetics. See the synergy with meals. People eat, insulin and amylin, both of them rise and fall together. This process, this nice physiological response, is absent in or defective in type 1 and type 2 diabetes. Therefore, supplementation of amylin or the medication, what we call a Simlin, if we supply that, with the meal, we achieve a similar physiological picture. And this is how it is deficient in diabetes. It's supposed to go up in the deficient people. They don't have a rise, and in type 1s, they don't have at all any rise. So they are really deficient, not insufficient. So the analog or the medication that has been mimicking or look like amylin structure, it's pramlintide, which is, as I mentioned, is Simlin for simplicity. It's a stable compound, and it is equipotent to amylin that we make in our or from our pancreas, and it's administered by mealtime subcutaneous injection. That's a drawback. There is ongoing studies to do a long-acting amylin or Simlin that lasts for a week. It's not yet approved. The FDA has approved its use for both type 1 and type 2 diabetics. It regulates post-meal blood glucose level by slowing, I repeat, gastric emptying, suppressing the abnormal postprandial rise of glucagon in patients with diabetics. Also, exogenous insulin therapy allows it to be more easily matched the physiological effect. As I show you, the rise and fall in both of those hormones we can achieve together by insulin pump and or multiple insulin injections. And the supraphysiological doses of this medication does not provoke hypoglycemia in normal subject, and that's a big plus. And Simlin or pramlintide does not interfere with the recovery from insulin-induced hypoglycemia, meaning it's present as if somebody has hypoglycemia, glucagon secretion increase, and patient could easily recover from hypoglycemia, and it has no effect on that. So these are all pluses and very good on weight loss. If you had used it in type 2s, you'll be amazed. There's a huge, a nice insulin drop in weight. And these are just the metabolic effect of it on plasma glucose, on glucagon, and triglyceride. Triglyceride is tightly related to glucose control. As you all know, it's really driven almost purely by glucose and not by fat. So with insulin use, the overall changes in hemoglobin A1C just by insulin, this is while it drops really dramatically when you use the Simlin together with it. And we use it, the dosing is different between type 1 and type 2 diabetics. In type 1 diabetics, we use very small amounts starting at 15 15, 30, 45, maximum is 60, while in type 2 diabetics, we give them a huge amount of, some studies goes up to 240, but the FDA approved dose is 120 microgram per meal injectable subcutaneously before meal, and the maximum glucose suppression is usually anticipated 3 hours after the injection, and therefore they should watch for hypoglycemia around this time. And it's used concomitantly with insulin. When we administer insulin at the same time with Symlin, we always ask the patient to give half of the dose of insulin, as it is together will achieve hypoglycemia much better, and that means you use less insulin, and finally this will lead to less weight gain. As you know, insulin is a fat making or lipogenic hormone, and therefore many people will achieve both glycemic control as well as less weight gain, if not weight loss. These are some trials about using Symlin and insulin together. The most important side effect in type 1 diabetics is nausea. That's why there is this graded dosing in those pens and or vials. You can use a small dose and you gradually go up on the dose until it's tolerated. And yes, tolerance will be achieved after a few days, maybe weeks. Sometimes people don't have at all any, some people sensitive, some people not, but the major problem is really nausea. Anorexia is one of also the side effect, but it's desirable as it decrease food intake and achieve decrease in weight. It's generally, as I said, well tolerated in terms of safety and tolerability. No evidence of cardiovascular, hepatic, or renal toxicity. No increase in the frequency of clinically significant lipid abnormality, EKG, which means heart monitor, heart issues, or vital signs and or lab abnormalities. As I mentioned, nausea was the only treatment emergent adverse event with an incidence of more than 10% and a twofold greater incidence in the patient treated with Symlin versus placebo. So in summary, insulin resistant and beta cell dysfunction and hepatic glucose overproduction result in both fasting and post-meal hyperglycemia in patients with type 2 diabetic. The incretins, which is the glucagon-like peptide, and glucagon, insulin, and amylin, they're all hormones naturally produced by pancreas, ileal cells, and all of them play a key role in glucose homeostasis. Multiple defect as well as the fasting glucose and postprandial are all appropriate targets. Therefore, all of these deficiencies are appropriate targets for therapy, directed all of them to improve the hemoglobin A1C. Exenatide, or for the public known as Byetta, and peramidinide, which is the Symlin, and DPP4 inhibitors like Januvia are all enhancers, the naturally occurring peptide hormones. All of them work together to improve glucose control. And many questions remain unanswered, and the clinical use, especially with the in terms of long term, but up to now, like safety, seem to be good enough, except, as I mentioned, for the pancreatitis reports with the Byetta. What else is new? Very quick. The endocannabinoid system, it's the system, it's in the brain, a family of endogenous lipids that it's in the brain, really regulates energy balance, food intake, lipid and glucose metabolism, centrally and peripherally. There is a receptor called CB1, cannabinoid receptor 1, and antagonism of these receptors promote could be potentially used in the future to treat what we call the metabolic syndrome. And the one, it's used in Europe and studied in Europe. It has not been yet FDA approved, it's still on hold. It's the Acomplia, or the Romanabant, you might hear about it. It's in a phase 3 trial in 6,000 patients, including diabetics. It shows that the Rio Europe study demonstrates significant reduction in weight circumference, improvement in glycemic and lipid control, and voted not to recommend, the FDA to recommend this approval for it, because the major side effect was depression. And as you know, I don't know, I will mention it, cannabinoid receptor is really the the people smoke pot, it stimulates their appetite and euphoria. So this is basically an it's something that antagonizes that receptor, so decreases appetite and causes depression. And the effect of depression was so high, or the depression was so high in those patients, and therefore it was put on hold to be used. But it achieves a tremendous amount of weight loss, as well as triglyceride drop, glucose improvement, and improves the metabolic syndrome. If it will ever be approved in the United States, it would be for the treatment of a metabolic syndrome. Islet cell transplantation, I'm sure you are all heard about. Initial reports were overly optimistic. I was involved with was an NIH with the islet cell transplant. It was used for incapacitating diabetes type 1, require high dose of immunosuppression therapy. It was complicated, and 2 or more, you need more than 1 islet infusion, and most patients require insulin treatment even after 5 years, and therefore was halted and stopped. So basically, in summary, Byetta or exenatide, it works with quotient to pancreatitis. Sustained release version of Januvia will broaden its use. It's an excellent oral therapy to the known biguanides, metformin, as well as sulfonylurea. Symlin, pramlintide, is useful in the motivated patient. It's another injection, but works excellently in glucose control as well as weight loss. And islet cell is still transplantation is still experimental, and the anti-cannabinoid receptor causes weight loss but unacceptable psychiatric problems. Thank you.
Questions?
Only all type 1s, please.
In all the tests, we're always challenged with other medications. Right. And how that all comes together. I never see that part where it correlates.
It's very hard, but I mean, as physicians, let's say, we have I don't know if you have it, but when we prescribe medication, currently at least, we have, it tells you, when we prescribe it, we have the system, you plug it in, and you combine them together, and it tells you what kind of interaction. This is in general. Sometimes you have to go back, and very rarely, I mean, always they ask, any SSRIs do not react with these. If you want this, in general. I can't recall any of those interact significantly with any other medications, really, no honesty. But we do have this tool that we can look up. I don't know if it's for the public, but as physicians, we have a way of putting them all together, and it tells you A, B, C, like what kind of interaction, potential reaction, interference, increased effect, or something. Or sometimes we go ourselves, and look at the package insert and see if there's action. We have the micromedics.
Comment on the age at which the FDA approves a lot of these medications.
Well, most of them adults, and usually, some say 16, some 18 adults. Except, Symlin, I don't know if Symlin is because it's approved for type 1, but the age is not like, not juvenile, really, like not the 5 or 6.
I've used Byetta in kids, but I use it with older kids.
The older kids, yes. I like to see that. The only thing is it's multiple injections, but hopefully there is in the pipeline a long-acting system, as well as all of them are potential.
Nobody is excited about 3 more shots.
Nobody is more excited, yeah. But it's really, for the motivated, I have a couple of patients, they were like 290 pounds and 300 pounds. They lost 50, 70 pounds using a combination of insulin and semen. No matter what, I mean, it's a huge achievement. Not really much change, they change their diet, but not major. But the appetite suppressing effect of Symlin is very, very potent. And they tell you, some people say, like, that's what they say. These are the comments you get. They don't want to eat. They don't want to eat. And that's good. That's very, very good.
Thank you.
So we'll have a 10-minute break, and then we'll be right back for